Hey guys, Robo here. This is a presentation on the workup and acute management of heart failure. I'll be going over some classifications and treatment/management plans for this condition when a patient presents with this. The purpose of this video is to have a guide mainly tailored to junior residents and interns. Note that the guideline recommendations are the most current as of December of 2023. Let's get started. Starting off with a bit of history here, Franklin Delano Roosevelt was President of the United States from 1933 until his death in 1945, and was known to suffer from a number of health problems, including hypertension-related complications, one of which was congestive heart failure. His blood pressure recordings have been published by his cardiologist, Dr. Howard Bruin, as shown on the right here. In April of 1945, President Roosevelt would suffer an intracranial hemorrhage secondary to hypertensive emergency, with a reported blood pressure at the time of 350/195. He passed away roughly 2 hours after the onset of symptoms, leading to his vice president, Harry Truman, taking his place as the 33rd President of the United States. President Franklin's death later sparked the creation of the Framingham Study in 1948, a longitudinal study meant to investigate hypertension and heart failure in a multi-generational setting starting in Framingham, Massachusetts, and later Paintsville, Kentucky. It is from this study that researchers discovered a number of risk factors associated with both heart failure and ASCVD, including hypertension, smoking, obesity, elevated cholesterol, and sedentary lifestyle. It is also from the study that was born the Framingham criteria, which are a set of criteria used to diagnose heart failure exacerbation in patients. Note that the criteria listed here require at least 2 major criteria, or 1 major and 1 minor criteria to meet diagnosis, with a sensitivity of 100% being the current gold standard for diagnosis, and a specificity of around 80%. It's important to note that heart failure exacerbation is thus diagnosed clinically by the criteria above, and not empirically by testing for troponin, BMP, or TTE. As an example of why, using BMP for diagnosis, BMP testing with a cutoff of 100 only had a sensitivity of 90% and a specificity of 73%, thus making it inferior to the Framingham criteria for diagnosis of heart failure exacerbation. It's important to note that you should not dismiss the use of such tests in the evaluation of heart failure, as these values serve their purpose in the evaluation and classification of heart failure, as we'll see later. The point I'm trying to make is that it is incorrect to say something like get an echo or a BMP to rule out heart failure, since the diagnosis is clinical, not empiric. Moving on to the classification of heart failure, there are essentially 2 metrics that classify the patient's heart failure status: the ACC/AHA staging and the NYHA staging. Although I'll describe these as separate entities, they can be used to describe the same stage. Special consideration should be taken with NYHA staging, since NYHA 2 and 3 tends to be more subjective than 1 or 4, as we'll see later. Starting with ACC/AHA stage A, these are patients that have predisposing conditions to heart failure such as hypertension, ASCVD, obesity, or diabetes, but no overt diagnosis of heart failure and no evidence of cardiac strain on imaging or blood work. Stage B encompasses patients that do not carry a diagnosis of heart failure, similar to stage A, but unlike stage A, do actually carry evidence of cardiac strain, either as structural heart disease such as ventricular hypertrophy or decreased ejection fraction, evidence of increased filling pressures, or persistently elevated biomarkers in the absence of confounders such as CKD, PE, myocarditis, etc. Stage C includes patients that have a history or are currently having a symptomatic heart failure exacerbation. Lastly, Stage D includes heart failure patients that have persistent symptoms despite optimization of medical therapy. This classification is important as it allows us to direct therapeutic goals and ascribe prognosis to each stage. Stage A and B both carry a 5-year survival rate of over 95%, which makes sense given these patients haven't yet been diagnosed with heart failure exacerbations. By comparison, Stage C sees a dramatic decrease in survival rates from 96% to 75% 5-year survival, and Stage D shows about a 20% 5-year survival rate. Now, let's compare the ACC/AHA staging to the NYHA Functional Staging. NYHA Class 1 includes asymptomatic patients, including during physical activity. Class 2 patients have mild symptoms with limitations in physical activity. Stage 3 has marked limitations in activity, and Stage 4 shows not only severe limitations/inability to carry out any physical activity, but also includes symptoms at rest. Note that while NYHA 1 and 4 have clearly defined inclusion criteria, NYHA 2 and 3 do not, since what a patient and physician describes as mild or marked heart failure symptoms is subjective. This has led to a large variance in prognosis even when comparing large landmark trials. One example is the TOPGET study, which estimated NYHA Class 3 patients to have a 12% mortality at 20 months, while the GUIDED study estimated 26% mortality at 20 months, a difference of more than 100% between the two studies. Also note that NYHA staging fits into ACC/AHA staging, where, for example, NYHA Class 1 patients describes patients who are in ACC/AHA stage B or C. Now let's discuss the management of an acute heart failure exacerbation, which, as we saw on the previous slides, means ACC/AHA stage C. Per Michigan Medicine inpatient diuretic guidelines, the goal diuresis is to hit a urine output goal of greater than 150 cc's per hour, or 3.6 liters output per day, while restricting PO fluid intake to a maximum of 2 liters per day. This adds up to a net fluid output minimum of at least 1.6 liters per day, with a goal diuresis endpoint back to dry weight. Note that orders should include a 2-liter fluid restriction, a sub 2 gram sodium dietary restriction, vitals Q4, I's and O's Q4, daily weights, and a BMP plus Mg BID to monitor electrolytes and creatinine for overdiuresis, as well as bicarb for contraction alkalosis from overdiuresis. Lastly, your diuretic orders, which are as follows. The first-line diuretic therapy for heart failure exacerbation includes loop diuretics, of which there are 4. Bumex, which has the shortest half-life at 1 hour, Lasix, torsemide, and ethacrynic acid. Note that the maximum recommended dose per FDA label is 10 mg total for daily Bumex, 600 mg oral daily for Lasix, 200 mg daily for torsemide, and 400 mg daily for ethacrynic acid. Also note that all of these diuretics have about 100% bioavailability, except for Lasix, which is around 50%, which is why the conversion from PO to IV is 2-to-1 for Lasix. Second-line diuretic therapies include thiazide diuretics, of which there are many, including metolazone, which is most often chosen for heart failure exacerbations, and HCTZ. Note that clinical trials have not found a benefit for metolazone over other thiazides except in the setting of CKD. Also note that you should only advance to thiazide therapy after you have maxed out your loop diuretic, since studies have shown that the addition of thiazides has increased mortality relative to maximizing loop diuretics, namely due to increased hyperkalemia, AKI, and morbidity as a result of that. Lastly, consider spironolactone for the management of hyperkalemia in addition to supplementation, since it is also useful for the implementation of GDMT. Moving on to chronic management, ACC/AHA stage A patients are mainly managed by primary prevention, namely treating whatever predisposing conditions they have, i.e. hypertension, hyperlipidemia, etc. Stage B is similar to stage A, with the exception of adding an ASI or an ARB and a beta blocker if the ejection fraction is below 40%, as well as consulting cardiology for an ICD placement if the ejection fraction is less than 30% at 40 days post-MI. Stage C is where GDMT begins for patients with HFrEF, or heart failure with an ejection fraction below 40%. For starters, it's important to understand that of the RAS inhibitor class, neprilysin inhibitors, or ARNIs, are superior to ASIs or ARBs. For beta blockers, only carvedilol, metoprolol succinate, and bisoprolol have currently showed mortality benefit for patients with HFrEF. For SGLT2 inhibitors, dapagliflozin has shown slight benefit over empagliflozin in one meta-analysis, although this will likely require further studies to confirm. For MRAs, start with spironolactone and switch to eplerenone if the patient experiences gynecomastia. Lastly, if the patient retains an ejection fraction below 35% with symptoms while on GDMT after the resolution of their exacerbation, they are indicated for an ICD placement. Touching on GDMT for HFpEF briefly, the evidence for the use of GDMT has not shown mortality benefit for HFpEF like it has in HFrEF, with the exception of SGLT2 inhibitors. In fact, beta blockers have not shown any benefit as of 2023 for the chronic management of HFpEF. RAS inhibitors and MRIs have shown some benefit in terms of reducing hospitalization, but not mortality. SGLT2 inhibitors, however, have shown some mortality benefit in HFpEF patients, so the use of these drugs should be considered in patients with HFpEF. Also note that for all of these, the target dose is that which was achieved in clinical trials, which I have linked to the right of this slide here. Lastly, remember that the use of neprilysin inhibitors will prevent you from using BMP for further evaluation of heart failure, since neprilysin inhibitors function by inhibiting the breakdown of BMP, and thus these patients will have artificially elevated BMP at all times while on that drug. Finally, for stage D patients, the mainstay of treatment usually revolves around referral to heart failure specialists with motions towards LVAD, heart transplant, or goals of care discussions/palliative care. That about summarizes the diagnosis and management of heart failure. That's it for me. Let me know if you have any comments or corrections in the comments below. Best of luck.